Hi, my name is Irbaz Riaz. I'm a GU medical oncologist at Mayo Clinic in Arizona.
Hi, I'm Roopesh Kantala. I'm a medical oncologist at Ironwood Cancer and Research Centers in Mesa, GU Oncology as well.
James Ewing, I'm a medical oncologist with a GU subspecialty, also with Ironwood in the Phoenix, Scottsdale area.
And I'm Chad Cherington, also with Ironwood Cancer Research Center, particularly focusing in genitourinary oncology in Chandler, Arizona.
Thank you, gentlemen. We're going to start our discussion with metastatic hormone-sensitive prostate cancer and then transition to metastatic castration-resistant prostate cancer. So maybe we should start with the basics and talk about how do you define metastatic hormone-sensitive prostate cancer in our practices?
I can take that one for sure. Usually patients who have not seen androgen deprivation therapy yet and who have presented with signs and symptoms of metastatic disease or have asymptomatic metastatic disease, primarily bone disease in where I practice in, and those are the patients I define them as hormone-sensitive metastatic prostate cancer.
Do you have any additional thoughts?
I think the other way to think about it is those who are castrate resistant and those that have a rising PSA despite androgen deprivation therapy and a castrate level, testosterone level less than 50.
So when a patient presents with hormone-sensitive disease, what is your usual practice in terms of initial metastatic workup? Are we still doing conventional scans? Are we doing PSMA PET scans for the staging of prostate cancer?
Preferred is PSMA PET scan. It depends on, I guess, certain financial factors where certain carriers don't cover that. So in such situations, I still rely a bit, not a lot, but a bit on the conventional CAT scans and bone scan.
Concurrently with conventional imaging, such as a CAT scan, PSMA PET scan is preferred in this setting for my practice.
Is your practice similar, or do you have any different thoughts?
No, I usually will first think of the PET PSMA scan, particularly if the PSA is greater than 0.5, or I think they're going to qualify under insurance, and I think they're high risk to have metastatic disease.
So in addition to conventional risk stratification, when we do the scans and we try to think about, let's say in the conventional scans era, if you're not doing PSMA PET scans, if you're just doing CT scan and nuclear medicine bone scans, the way I think about these patients is usually by charted criteria. Is it high volume disease? Is it low volume disease? And that kind of helps me guide, in addition to synchronous or metaconous presentation, helps me guide, how aggressive we be in the treatment of, initial metastatic prostate cancer. When you do a PET scan in the initial staging of prostate cancer, do you still think about these concepts of high volume, low volume disease?
I think so. You're still thinking about what the volume of disease is, the location of metastases, for instance, liver metastases versus bone or lymph node only. But it's going to be more sensitive than conventional imaging, so you're going to have some stage migration, certainly, using the PET PSMA up front.